Welcome to one of the most critical topics in immunohematology. ABO grouping is the most frequently performed test in the blood bank, and because of its clinical significance, it requires the highest level of accuracy. Today we are discussing ABO discrepancies, which occur whenever the results of red cell testing or the forward typing or forward grouping do not agree with the results of serum or plasma testing, such as in the reverse grouping or in the reverse typing. Our foundation for this discussion is the Landsteiner's rule, which states that healthy individuals possess ABO antibodies to the A or B antigens that are absent from their own red cells. Under normal circumstances, we expect to see an inverse reciprocal relationship between the forward and reverse types. For example, a group A individual should naturally have anti-B in their serum. When this relationship is broken, we must identify the cause and resolve the discrepancy before any donor units are labeled or any recipient receives a transfusion. The primary reason we are so meticulous is safety. The transfusion of ABO incompatible blood can cause the immediate destruction of red cells, leading to a potentially fatal acute hemolytic transfusion reaction. When you encounter a discrepancy, your first step is always to rule out technical errors such as simple misidentification, failure to add reagents, or incorrect reading of results. An ABO discrepancy occurs when the results of red cell testing or the forward grouping do not agree with the results of the serum or plasma testing or in the reverse grouping. Under Landsteiner's rule, we expect an inverse relationship. So if you have the antigen, you lack the antibody, and vice versa. So when the laboratory observes something different, it must be resolved before a blood type can be safely assigned. The observations in ABO discrepancies are generally categorized into 4 types based on what is seen in the test tube. So we have the first one, the weak or missing reactions, such as in Group 1 and Group 2 discrepancies. So in these cases, a reaction that should be strong, typically 3 plus to 4 plus, is either very faint or completely absent. So we have missing antibodies in the reverse grouping. This is the most common observation. It is often seen in newborns who haven't started making their own antibodies, in elderly patients whose antibody levels have declined, or patients with hypogammaglobulinemia due to leukemia, lymphoma, or immunosuppressive drugs. We also have the missing or the weak antigens, such as in the forward grouping. So this is less common and usually involves rare ABO subgroups like the A3 or AX that have very few antigen sites on the red cell. It can also occur in patients with leukemia or Hodgkin's lymphoma or Hodgkin's disease, so which can depress the expression of antigens on the red cells. Next, we have extra reactions in the forward grouping, such as in Group 2 discrepancy. So this happens when the red cells clump with a reagent they shouldn't react with, making the patient appear to have an extra antigen. We also have the so-called acquired B antigen. This is usually seen in Group A individuals with lower gastrointestinal diseases or colon cancer. Bacterial enzymes will modify the immunodominant sugar of your A to look like an immunodominant sugar of B, so causing the cells to react quickly with anti-B reagents. So you also have the B close and open parenthesis A phenotype. A group B individual may react quickly with anti-A because their B enzyme is so efficient that it accidentally attaches trace amounts of the immunodominant sugar of A to the red cells. We also have the Wharton's jelly. In cord blood samples, this gelatinous substance can cause the red cells to stick together non-specifically, looking like a positive reaction. So extra reactions in the reverse grouping, such as in Group 3 and Group 4, this occurs when the patient's serum clumps the reagent cells that should be compatible, so suggesting an extra antibody is present. So could be due to RULU, in which high protein levels seen in multiple myeloma cause red cells to stack like stacked coins. This looks like agglutination, but it is actually a physical stickiness that can be dispersed by adding saline or performing saline replacement technique. So we also have subgroups with anti-A. An A2 or an A2B individual may produce a naturally occurring anti-A1 antibody, which will cause their serum to react with the reagent A1 cells used in the laboratory. We also have the cold allo or autoantibodies. Antibodies like anti-big I, anti-big M, or anti-P1 react best at room temperature. Since reverse grouping is done at room temperature, these antibodies may clump the reagent cells regardless of the ABO type. We also have mixed field reactions. So this is a unique observation where you see small clumps of cells floating in a sea of unagglutinated cells. So we also have um, patients who have undergone transfusion or transplant. So this most often occurs if a patient was recently transfused with group O cells but is actually group A, B, or AB. It is also seen in bone marrow transplant recipients who are currently transitioning from their original blood type to the donor's blood type. We also have A3 subgroup. This rare subgroup is genetically programmed to always show a mixed field pattern when tested with anti-A. So ABO discrepancies must be resolved before a blood type can be safely assigned to a patient or donor. So rule out technical errors first, as they are the most frequent cause of these mismatches. Technical errors are generally categorized into three main areas. So we have identification documentation errors, we have reagent and equipment errors, we also have standard operation procedure errors. So ID and documentation errors, so these are often referred to as clerical errors and are a leading cause of transfusion-related fatalities. Common mistakes include incorrect labeling of the blood specimens, test tubes, or slides, patient misidentification during sample collection or testing, recording errors such as documenting the correct test result on the wrong patient record, or simple transcription mistakes, failure to notice hemolysis, which must be interpreted as a positive reaction in the blood bank. So for reagent and equipment, it must be properly maintained and monitored to ensure accurate results. So we have also reagent deterioration. If reagents lose their potency or the strength, they may produce weak or false negative reactions. Contamination also, using contaminated reagents can lead to false results. Centrifugation issues. If a centrifuge is uncalibrated, over-centrifugation may cause clumps that won't disperse, which can cause false positive reaction, while under-centrifugation may fail to bring cells together for a reaction or a false negative. So in order to reduce errors, manufacturers add blue dye to anti-A and yellow dye to anti-B, so we can easily see if the correct reagent was added. For SOP errors, so these occur when we fail to follow the manufacturer's directions or established laboratory protocols. So let's say for instance, failure to add reagents or samples. So this is a common error that results in a false negative reaction. Incorrect red cell suspension. So if the red cell suspension is too heavy or thick or too light or thin, it can interfere with the optimal antigen-antibody ratio, leading to a post-zone or a pro-zone effect where clumping is missed. So the order of addition, we are taught to always add clear solutions or the serum or the reagents first and the red cell second to visually confirm that both components are in the tube. So inadequate resuspension. So if the button of red cells at the bottom of the tube is not completely dislodged and shaken gently before grading, the reaction may be misinterpreted. So if a technical error is suspected, the first step is to repeat the ABO typing on the same sample. Washing the patient's red cells several times with saline can help remove interfering proteins or substances. If the discrepancy persists and an error in specimen collection or identification is suspected, a completely new sample must be obtained from the patient and tested. So while the investigation is ongoing, if the patient requires an urgent transfusion, Group O red cells should be administered.